Um, Dr. Tsang, are you going to do the introductions here, or how would you like this to go?
Hi. Actually, Diane and I have asked Dr. Abolmaesumi to actually do the moderator business. I was going to, and then I still have this cough that just get into paroxysms that really inhibit me from actually talking too much. So, yeah. So is Purang here?
Not yet.
Diane.
I don't think he
Not
joined.
yet. Okay, no problem. Yeah. So, it's entirely up to you, actually.
No, it's okay.
Teresa.
I don't feel the need to.
Yeah.
If you guys, so you have a plan, that's all good.
Yes, we do.
And if so that's great. And thank you for arranging this.
No, our pleasure. Absolutely our pleasure. So we will be ready in about 1 minute. Yeah.
Yeah, and usually we start as like most rounds, we let people, well, it's not really drifting in
Nice.
virtual, but like start a couple of minutes after the hour.
Great,
But,
super.
Sneha, what's up next week?
Yeah, let me check, Dr. Henson.
Okay, thanks. Maybe send me an email or something, or just if you let me know, it would be great. Thanks.
Yeah, next week, Dr. Henson, it's Dr. Lee Wu, who is presenting on research round.
Oh, okay, that's the research presentation. Okay.
Yeah.
So yes, and it's on RNA biology. Fantastic. Okay. So then what I'll do is I'll say a couple of words first, and then who did you say was going to be introduced, moderating the session?
It's going to be mostly Dr. Abolmaesumi. Purang, Dr. Purang. Yeah, he's my our partner in data science, and he's from engineering. And he works very closely with us. And he will be here in a minute, he said. Yeah. Thanks for hosting us. Really appreciate it. Appreciate the opportunity.
And Dr. Mamdani, thanks for joining us.
My pleasure. Thank you. Just give me 1 minute. I'll be right back.
Yes.
Hi, everybody. Hello.
Hey, how you doing? So I think we're ready to go. So Purang, so I've met you with Ali Bashashati a while ago, and thank you for joining us today. Why don't we start now? Welcome to Province-Wide Pathology Rounds. We are hosting what I think will be a really exciting session on the possibilities of AI in medicine and an important collaborative initiative which we could connect with as a department or as individuals. As you all know, there's a lot of tremendous bioinformatics and actually AI research attached to pathology led by Ali Bashashati, Andy Roth, Youngjin Park and others in our department. But I think here we're going to be looking at broader manifestations of the potential. So before we start, I'm just going to mention that next week's presentation is by Dr. Li Vu from the Terry Fox Labs, and she's an expert in RNA biology. And a huge amount has changed in what we understand about RNA, different species of RNA, how it is processed, how it operates within cells. And so I thought it would really benefit us all, myself included, of course, to get a lecture on what's been going on in RNA in the last 15 to 20 years. I think we'll be all educated, and it should be a really enjoyable session as well. So I'll see you all next week. So at this point, I would like to turn the microphone over to Professor Purang Abolmaesumi, and who's going to be introducing today's talks. So thank you so much. And thank you,
thank you so much,
Professor Tsang, for helping to arrange this.
Thank you, really appreciate it. Let me share my screen and then I'll start. So first, I want to thank the Department of Pathology for allowing us to host this event today. I guess just kind of for a way of introduction, I guess Mohammed, we met kind of, I don't remember when it was maybe during COVID, I guess it was a few years ago. But great to see you, and great to see you, Amol, as well. I'm one of the innovation leads for the UBC Data Science and Health Research Excellence Cluster, along with Dr. Tsang. Before we start, I want to acknowledge that I am calling from Vancouver campus of UBC, which is situated on the traditional ancestral territories of the Coast Salish peoples. That includes the Musqueam, Squamish, and Tsleil-Waututh nations. The Data Science and Health cluster at UBC started in 2021 with the goal of multidisciplinary and multi-jurisdictional way to bridge the gap between BC's health system, data, and the data science and research infrastructure at UBC. And the objective of it is really to drive innovation and hopefully improve healthcare, which is important in terms of improving the operational and clinical kind of mandates for patients and providers. The DASH co-leads are Dr. Anita Palepu, who is the head of the Departments of Medicine at UBC and St. Paul's, and also Dr. Teresa Tsang, who is the Associate Head Research of UBC Department of Medicine and Director of the AI Echo Core Lab at the VGH. This is an overview of DASH's major activities, which kind of aims to bring together infrastructure, process, culture, and education components needed to realize the potential of health data. And as part of this, we are launching this rounds series, and as part of kind of the Department of Pathology kind of sessions, and really kind of we want to acknowledge really the amazing pioneering work that the teams in pathology and laboratory medicine community have been doing in this domain in terms of integrating data analytics and advances that they have made in the domain of digital pathology to bring areas in image analysis and telepathology, personalized oncogenomics, lab workflow optimization, and many more. And also we are really excited to learn from the experience that you guys have and also figure out ways for future collaboration for close partnership with also data scientists and engineers that can help making even more improvements. We host these rounds on an ongoing basis to expand, and we plan to expand it to other disciplines in medicine. And the purpose of the rounds are to develop critical links between the stakeholders and support pilot projects that can address key challenges using data, bring together teams that can work on these problems collaboratively. And we hope to identify the barriers that exist to advance in this kind of work, developing strategies to better integrate analytics in our healthcare system, and also be able to create a community of practice and learn from each other to move this field forward in BC and across Canada. With that, I want to introduce our guest today, Dr. Mohammed Mamdani, who is a Vice President of Data Science and Advanced Analytics at Unity Health Toronto and Director of the University Toronto Temerty Faculty of Medicine Center of AI, Education and Research in Medicine. And Dr. Mamdani's team bridges advanced analytics, including machine learning, with clinical and management decision-making to improve patient outcomes and hospital efficiency. And Dr. Amol Verma, who is a physician, scientist, and assistant professor in general internal medicine at St. Michael's Hospital and University of Toronto, and the 2023 Temerty Professor of AI Research and Education in Medicine at the University of Toronto. He's a health services researcher and also studies and improves hospital care using electronic clinical data. And he co-founded and co-leads Gemini, one of Canada's largest hospital clinical data research networks, which is collecting data from more than 30 hospitals in Ontario. The team is a leader in establishing world-class educational programs in AI medicine, funding research opportunities that bring together experts from a range of disciplines, and has created a secure data platform to host data sets for applied AI learning and research. And we have an opportunity today to learn from them, and hopefully together we can advance capabilities in this field in BC and across Canada. Thank you so much for accepting our invitation and joining us. Please take over with your presentation.
Great. Thank you, Purang. It's great to be here and terrific to see you again. I'm just going to share my screen. All right. People can see it? Fantastic. All right. Thanks. It's a pleasure to be here. I want to start off by saying what everyone knows. AI is pretty much everywhere, right? And it's not new. It's been around for a while. So whether we realize it or not, we're using AI quite frequently in society, through whether it be through Amazon, you do your shopping there, it uses a lot of AI algorithms. Google Maps, something I use practically every day, is all driven by AI. Airbnb, Netflix, Uber, our smartphones with Siri, Google Assistant. I guess you pick your poison in terms of which assistant you want, but we use all of these things routinely. It's kind of how we live in society these days, is reliance on these technologies, these tools, and these solutions and these services. And of course, many of us have kind of opened up to AI quite a bit through this more recent advancement of ChatGPT and OpenAI. I'm sure everyone's heard of it. If you haven't, you must be living under a rock. It's been front, left, and center. And I'm sure many of you have used ChatGPT. These large language models have actually changed the dialogue with respect to AI. What does that mean in terms of what AI is? For people who need a basic description of things, there's one on Coursera. There's lots of these definitions out there. This is what I'm going to use for the purposes of this talk. Coursera defines AI as something that uses computer science and data to enable problem solving in machines. I think at the very simplest level, though, AI is really about learning complex relationships and data. And you can argue that's statistical modeling or statistics in general or data science in general, but I view AI as really trying to get at complex relationships in data. Machine learning is viewed as a subset of AI. And historically, when we do mathematical models, we can actually define a lot of parameters. So we can say, all right, here are I'm trying to predict X, and there are 40 things that predict X. I'm going to define exactly what these 40 things are. And actually, I can define the interrelationships between these 40 things, and the computer or the system will do the math for me. But I'm going to define very heavily what goes into the model. Whereas machine learning steps back and says, no, you know what, let me figure it out myself. I'll figure it out. I'll learn on my own. You go have a coffee and I'll let you know when you're done. And so basically, machine learning refers to the study of computer systems that learn and adapt automatically from experience without being explicitly programmed, right? So without really a lot of human intervention. That's in theory what machine learning is. Deep learning, what is that? It's basically machine learning, but with a lot more data and a lot more complexity. So it's kind of a quick overview of AI and machine learning. There's been a lot of activity in this space. So if we look at the number of publications, if we look back about not even 20 years, there was maybe a couple hundred publications maximum in PubMed. That has grown exponentially. We see over 15,000 publications each year now in this space. So lots and lots of activity in machine learning and deep learning in medicine. And it spans all sorts of disciplines and fields, from surgery to pathology to ophthalmology, practically every specialty of medicine. There's been some work in research using machine learning. What that's meant is that a lot of people are getting interested in the potential for machine learning to actually then drive care. So we actually are seeing more and more AI or machine learning enabled devices that are being approved by groups like the FDA over time. And again, exponential increases here as well. So currently there are hundreds and hundreds of these devices on the market available for purchase. Simple things like if you go to Amazon, for example, there's a Cardia Mobile. You can buy it for, I think it's like $99. It attaches to your smartphone, and you put your two fingers on two sensors, and it's basically an ECG, right? It'll actually monitor your heart. These things are purchasable today. So we're going to see more and more of these solutions coming about. Why? Because the market drives it. So if we take a look at the healthcare market size for AI, it was estimated to increase from about 11 billion in 2021 to almost 200 billion in 2030. And I believe these estimates are actually a little bit older now, and they're even more aggressive today. So there's a huge market to actually drive adoption of AI into clinical practice. Where are we in Canada? Canada's really uniquely positioned because we're one of those few countries that has pretty good data assets, largely because we are a public healthcare system in general in Canada. And we have lots of groups, very well-known research groups, ICES, the Health Data Research Network, Canada, and based in BC. We have Alberta Health Services, which has a province-based approach to data, which is really exciting, Genome Canada, and so forth. We also have really good technical expertise from groups like the Vector Institute, AMI in Alberta, Mila, Montreal, Waterloo, AI, lots and lots of deep, deep technical expertise in machine learning and AI. We also have a lot of good clinical expertise. We have some of the world leading hospitals. On Tasman, for example, I believe Princess Margaret is one of the top 5 cancer hospitals in the world. Toronto General, I know, was named among the top hospitals in the world as well. But we have lots and lots of terrific hospitals and a lot of data in these hospitals. We also have really good primary care. Now, some will argue that we wish it was more accessible, but this public healthcare system does make it more amenable to actually have more centralized data. And of course, collaboration. Canadians are friendly. We tend to work together better than many other countries do. And so we have that kind of social bent to actually wanting to collaborate. Just a few examples of the types of things that people are doing. When we look across the spectrum, I'm just going to pick a couple local examples. In breast cancer, researchers at Sunnybrook have looked at algorithms to predict response to first-line chemotherapy, and it predicts response with 96% accuracy. So one of the things people struggle with is that they try first line, often doesn't work, and then you've got to actually wait and try something else. And it's much more efficient if we actually knew that something was going to work or wasn't going to work in a given patient. And the researchers in Sunnybrook have actually built algorithms that actually, I think, can predict it quite well. Researchers at the University Health Network, in Toronto General in particular, a surgeon named Dr. Mamdani has developed this really neat AI-guided surgery tool, where basically this is a video of a cholecystectomy, and he basically uses this machine learning driven solution that actually highlights areas of green where it's safe to cut, and areas of red where it's not so safe to cut because it has a much higher risk of causing a major bile duct injury. And again, all moving in real time to direct care. There are many of these solutions that are around, and when we actually look at all the brilliant minds that are putting these things together, they're located in different centers, different hospitals, different cities, different provinces. And one of the big challenges, how do we actually bring all these great minds together? Because wouldn't it be great, because we normally don't talk to each other, to have a venue where people did talk to each other? So a few years ago, the Temerty family in Toronto was very generous and gave a donation to the University of Toronto of about $26 million focused on AI medicine, to have an institute or a center for AI medicine. So this is where we thought it'd be great to create a network, not simply a center. And I'm going to tell you a little bit more about it, where we could try and bring together people with common interest to really advance things collectively in this space of AI medicine. So what is T-CAIREM, or the Temerty Center for Artificial Intelligence Research and Education in Medicine? Again, as I mentioned, it's supported by a generous donation from the Temerty family, and our goal really is to advance AI in medicine through multidisciplinary collaboration between relevant stakeholders, healthcare providers, statisticians, computer scientists, engineers, industry. This is very much a team sport. One of the notions that people have is that AI medicine is going to be driven by the clinical community, and I think that's very short-sighted. Most clinicians are not trained in machine learning or computer science or AI, but computer scientists are. Statisticians have a good foundation. Engineers are pretty good at this stuff too. All of us working together is really what's going to advance this field. So very much a multidisciplinary approach to the space. We were launched officially in October of 2020. What are some of the things that we do? So we're structured in 4 themes, 3 core themes surrounded by a community theme. So first, we start off with community. We have over 1,200 members in our network. They span 25 universities across the country. So we have 25 universities in our network with over 90 organizations that that are part of our membership. This makes us the largest, as far as I know, the largest active AI medicine network in the world, which is really exciting. In terms of research, we support research. We provided over almost $2 million now in research grants. We funded 12 research projects and we'll continue to fund more. In terms of education, we have a lot of activity in this space. So we have speaker series, so people can listen to some of the world leading experts in AI medicine. We do that typically monthly. We have trainee rounds. So these are multidisciplinary rounds of trainees that come together. Typically, it's about 80 to 100 trainees that come together every month, and they learn from each other. The way we structure it is typically there's a health trainee, so somebody in medicine usually, and then there's a trainee who's not in health or medicine, so maybe computer science or statistics or engineering, and they get to present. And again, the trainees just learn from each other using this multidisciplinary approach. We also have studentships and internships. For example, this past summer, we funded 29 summer students. Next year, we'll fund about 30. Lots of opportunities for people to learn. We also have curated materials, and I'm going to talk about that in a bit, for people who want to learn. So there's some people who are going to say, I know nothing about AI. Just want to learn the basics. And there's curated materials for that. More and more, we're seeing good material, but we're also seeing bad material. And so we have a group of people who spend their time literally monthly to go through new materials that are out there that are available and vet them to say, this isn't so good, but this is very good. And we've assimilated that material. Infrastructure, that's something I'm going to talk about as well. You can't do AI without data, and that becomes really, really important. And many researchers, I'm sure many of you can empathize with me. A lot of times when we collect data, because research is all about data, either you have data or you get data, right? You have data, or you actually go and prospectively collect it. But you got to put it somewhere. You got to manage it somewhere. You got an area where you can actually have sufficient compute, especially for compute-intensive applications like machine learning. So we actually created an environment on Google Cloud, and that's available to any academic in the country, which is really exciting. We have over 150 users with 5 public data sets that are vetted and online right now, and that's growing, which is exciting. Talking a little about the Health Data Nexus, it's 1 part data access platform, 1 part analytics platform. So again, we have several data sets that are available right now. We're growing that pretty aggressively in the next year, which will be really exciting. And we have 3 zones. We'd really like data to be as open as possible for people, because data is hard enough to get access to. And in AI and medicine, most people use, well, not most, but a lot of people use Mimic. That's a very common data set that a lot of people have heard of. This is out of Boston, where it's really focused on critical care data, and it's very easily attainable by academics because they've made it open. So the way we structured Health Data Nexus is we have Zone 1, which is really supposed to emulate that. The ethics approval happens on the back end when people submit data. It doesn't happen for the researcher who wants to access the data. So if you're a researcher who wants access to publicly available data, in Zone 1, you don't need ethics approval. You don't need a detailed analytics plan. You just have access to data. There's 3 things that we need, though. First, you have to prove to us that you're a researcher from an accredited university, and that's literally by your email. The second is you can show us that you have TCPS2 training that most clinical researchers do. And the third is to read a user agreement and click I agree, and you'll have access to data. Very rapid, very quick, very painless. Zone 2 says, well, okay, the person who contributed, or the group who contributed the data, they have a few more requirements, and maybe they want to vet your ideas. So proposals are sent to the contributor body, and the contributor body says, I like this one. Okay, fine, grant them permission, and then they have access to the data. And Zone 3 is very typical, traditional, old-fashioned, where you need research ethics approval, and in the ethics approval, it outlines who can have access to it, and those are the only ones that get access. So it does cater to a variety of groups of people. We'd love for as many things as possible to be in Zone 1, because we do believe that data should be readily available. And what we want to do is have a safe environment that has all the precautions in place that can accelerate research and scale compute. The nice thing about Google Cloud is there's no queues. You have virtually unlimited compute, virtually unlimited storage. And our target audiences are not just researchers, they're students and learners as well. We have, and the way we structured this, again, is in a responsible manner, creating a data governance committee with data transfer agreements for contributors, data use agreements, code of conducts. There's research training that we have available. We have zoned access, and we've done privacy impact and threat risk assessments. So it is a fairly good, secure environment that's made for AI and medicine. And we have access to tools, obviously, like Python and R and such, that are typically used. So using this environment, it really depends on what your needs are. Some people may come in and say, I just want to do some research. I want access to data to do some research. Well, there are data sets on there, and you can get access pretty easily. And if you want to contribute data, even better. We'd be more than happy for you to contribute data to the environment. If you want something that's high-powered with compute to support analyses, absolutely, that's there as well. If you want to run a datathon, and we actually ran one earlier this year, we have another one scheduled in the next few months. Datathons are a fun way of advancing initiatives in AI and medicine. We do that as well. Or if you're a professor who says, you know, I'm used to telling my class to go look for a data set or use Mimic. I'd like to be able to give them an assignment where I can just point them to the Health Data Nexus. We have 5 data sets right now. There's going to be many more in the next year. 2 weeks, the assignment is due, use this data set and circle back. That's available as well. In fact, we've had several professors use the Health Data Nexus for teaching purposes to do assignments for the classes. So again, lots of use cases here that we hope the community nationally and at some point internationally will be able to use the Health Data Nexus. We're also a member of the global AI medicine community. There's a group called ACAM, or the Alliance of Centers of Artificial Intelligence in Medicine, that meets monthly. There's over 80 other AI medicine centers around the world that meet monthly. So we're not a small group anymore. There's lots and lots of people here playing in this space. And T-CAIREM's done quite a bit. Unfortunately, last year we were named as the Institution of the Year and received an award for it because of the work that we've been able to do. As I mentioned, we're a national network. So we have 25 universities, over 90 organizations across the country with over 1,200 members. But we also have international collaborations. So, and this is the website for anyone who wants to join. We welcome everybody. There's no cost to join. It is, again, all funded through philanthropic dollars. And we want to grow our community as much as possible. On the international side, we have an MOU with Technion. And we actually have had a visit over there. We sent 20 University of Toronto faculty and students over there just this past summer, and to collaborate with researchers in Technion, which has been quite fruitful. And of course, we have signed recently an MOU with the Indian Institute for Information Technology, and are exploring lots of collaborative activities there, including summer research studentships, speaker series, fellowships for postdoc trainees and such. I'd mentioned the education materials. So again, there's the speaker series that we have monthly. There's a tailored resources hub. If you go on the website, you'll see it. Summer research internships, trainee rounds, graduate scholarships. And we're actually working on programs for secondary school students as well, especially those who are underserved, to really advance AI medicine in high needs groups. So with that, I'll end by inviting everyone to join T-CAIREM. We'd love to have you as part of our community. Even if you're curious about AI in medicine, you don't know too much about it, but you'd like to learn, join us, visit our website, access materials, really advance knowledge in this space. I'm going to hand it over to Amol by saying just one thing. There's a lot of hype in AI. Deploying it is really, really, really tough. But I think the potential for AI machine learning to advance the care that is given to our patients and the outcomes that we see is immense. So when we're thinking about AI, there's lots of glamorous thoughts that we have. Putting it into practice, the reality can be quite challenging. And I'll hand it over to Amol to give you an actual case example of a real machine learning solution that has been deployed in clinical practice and some of the outcomes that we're seeing. Thank you.
Thanks, Mohammed. And it's a pleasure to be with you all today. Hopefully you can see my screen. Great. So as Mohammed said, I'll chat with you a little bit. I'd like to share with you some of the work we've done implementing a real machine learning-based early warning system for patient deterioration at St. Michael's Hospital here in Toronto. So just some disclosures at the beginning. I actually, along with Mohammed and two other people, are sort of formal co-inventors of the solution we'll talk about, which the hospital has since sold to a startup company. The company had no say in these slides, nor do I have an ongoing direct relationship with that company. So I'll start with just a case that I think all the clinicians in the audience would recognize, a case of patient deterioration, which is real, although some of the details have been changed to obfuscate the identity of the individual. So our team was taking care of an older retired nurse who was hospitalized with cholecystitis. The patient had an advanced endoscopic procedure, ERCP, to remove the culprit gallstone and was set to be discharged home the next day. Our team was called in the evening. The patient was feeling a bit short of breath. We ordered a chest x-ray, some lab results, handed over to the on-call resident overnight. And then overnight, the nurse checked the vital signs 2 times. And then our team was back the next morning, and we were called urgently while we were rounding that the patient was experiencing decreased blood pressure, in acute distress. The ICU team was called. The patient did not want ICU and passed away that day on our unit. And the family was distraught. They said we would never have left the bedside. And that she was suffering. And so, you know, this idea of the patient so-called crashing or unrecognized clinical deterioration is something we experience not infrequently on medicine. We know that about 5 to 10% of medical inpatients die or require ICU care. We also know that early warning systems have been deployed widely. I'm not sure if any are implemented in your hospitals. in more than 3 out of 4 UK hospitals and many others, they use different early warning scoring systems. Most of the existing scoring systems are quite simple. So the NEWS system is the one that's most commonly used, the National Early Warning Score. It basically takes 5 vital signs, computes them together, and spits out a score that basically recognizes whether a patient is experiencing clinical deterioration, but doesn't do too much to predict and has a lot of false alarms, which is really problematic. And so we asked, knowing that the #1 root cause of unplanned transfer to ICU is clinicians failing to rescue patients because we don't recognize clinical deterioration soon enough, we asked whether machine learning, an AI-based tool, could help clinicians intervene earlier by providing an early warning signal before patients become seriously ill. And so just asking that question has raised the question for us, which is, when should we consider AI? And so our group has recently put out, I think it was actually published today or yesterday in BMJ Quality and Safety, an article describing the implementation of machine learning in quality improvement initiatives. And we've kind of said, okay, here are the 5 or 6 things you should think about when AI might be beneficial. So obviously the first one is that it's an important problem because it's going to be resource intensive to develop or implement an AI solution. The second one is there's a current gap. There's some opportunity to improve something. And then importantly, that predicting something or automating something would actually lead to improvement. It addresses the underlying problem. That's a critically important step that often gets overlooked. Is often you'll have your computer scientists, data scientists doing amazing work over here. They say, we've created this great tool. But that tool doesn't necessarily, then the tool goes looking for a problem rather than a problem looking for a solution. And so it's much more valuable to start with the problem and say, could this problem benefit from prediction or automation? And skipping that gap can lead to problems down the road. And then it's really important that institutions have the data that are available and also is willing to invest in maintaining the solution, because just deploying something is not enough. These solutions need to be maintained over time. So we decided that patient deterioration prediction solution met these criteria and was worth deploying. And so we created what we call ChartWatch. It's an AI-based tool that takes data from the electronic health record and it predicts unplanned ICU transfers and death in hospital. The goals for implementing this solution were, 1, to reduce mortality; 2nd, to improve communication with patients and their families; to improve our coordination between the general internal medicine, palliative care services, and intensive care services, including physicians, nurses, coordinators, and then importantly, improve end-of-life care. So it's not just about reducing mortality, but also about in patients who, for example, don't want care escalated to the ICU, improving early access to symptom management and end-of-life care. So we also developed a framework for implementing machine learning solutions in QI, and specifically a 3-phase approach. So first is identifying the problem and exploring the problem. So in that phase, when we were exploring the problem, we actually did chart review on 20 deterioration events. We found that most deterioration events in our hospital had less than a 3-hour notice between the initial deterioration and the patient either going to the ICU or dying if it was an acute death, having an arrest or something like that. And so that led us to really think there is an opportunity if we had earlier information. So we did kind of a detailed chart review and some process mapping to figure out how this solution could work. Then we designed the model, the machine learning model, and then finally implementation and evaluation. And we actually created 3 teams to do this. So initially we just had an exploration team that was a few interested physicians, the chief resident, some data scientists, just to figure out what might we focus on. Once we decided that we were going to work on patient deterioration, we actually built out 3 separate teams with some overlapping membership so that there would be coordination across the team. So there was the model development team. This was our biostatisticians, computer scientists, etc. Then there was the implementation team. So interestingly, we made the implementation team actually start meeting right from the outset. And they were focused on developing what was the care pathway going to be for high-risk patients. How can we use this tool, and helped us get buy-in right from the outset. And then we had an evaluation team full of methodologists and others to help us design the actual evaluation. And then finally, once we launched, we collapsed those 3 teams into one team and took key members onto an implementation team that met weekly and reviewed the model's performance once it was in real life, reviewed any events. We solicited anecdotal feedback from colleagues. And so that was kind of the team-based approach to implementing. As you can see, it was no small endeavor. There was a lot of people involved, lots of meetings, and really collaborative. I mentioned that we designed a care pathway. So high-risk patients, it wasn't just a machine learning alert, but the high-risk patients had a care pathway. So if a patient got a first high-risk alert, the first question that the clinicians would ask is this patient already palliative? If yes, great, continue palliative care. If no, a physician from the team should reassess the patient within an hour, assess the patient for potential causes of clinical deterioration, and we provide some guidance around evidence, what the evidence tells us are common causes of clinical deterioration in medical inpatients. Our hospital's EMR was called Sorian, so it says place an order to increase the vital signs. This is the maximum that our nurses can monitor patients on our ward. The clinician was asked to review labs, medication, imaging orders to ensure they're appropriate, discuss the status and plans with the bedside nurse. So this is cultivating that nurse-physician kind of communication and interaction, considering escalating the patient to our step-up observation unit or involving our ICU outreach team, consider subspecialty consults, clarify and document goals of care. So this, I think, is actually where a huge value is this tool gives a warning 24 to 48 hours in advance of patient deterioration. And that gives us a chance to have those really meaningful, critical conversations in a way that's not as rushed as when they're happening right in the moment a patient is crashing. And we can try to clarify goals of care and then document everything that was done. So that's kind of what the care pathway is. Importantly, you'll notice there's no, the only instruction that is you must do this is the vital signs instruction. Everything else is review, assess. So essentially it's a triage tool, right? It's telling clinicians where to focus their effort, but it's not automating specific aspects of their care. It's just saying, use your clinical skills and apply them in this context. So it's really heightening the activity. It's in no way replacing the clinical expertise. So, when we had developed a machine learning model, I took it to my colleagues in the GIM division. I said, we have this machine learning tool that can predict patient deterioration. And they said, that's great. How do I know it's better than me? I think I'm pretty good at predicting patient deterioration. So how do I know this is going to be useful? So what we did was after we trained the model on 20,000 historical visits, we then sent a research assistant to the ward every day. And they asked physicians and nurses about the patients that they were caring for in that moment over 4 months. And they said, tell us which of your patients are likely to deteriorate, will die or need ICU in hospital. And we compared those clinical predictions to the model's predictions. And so what you see on this slide is the machine learning model's predictions here, the clinical predictions here, and then combined predictions if you combine the model predictions and clinicians. This white box is for the composite of ICU or death. Blue is for ICU alone, and purple is for death alone. So the first thing you can notice is that the machine learning, and the y-axis is F1 score, which is a balance of sensitivity and positive predictive value. So what you can see here is that the model achieved pretty close to human level performance on predicting the composite of ICU or death. So that was the first time that had been shown in the literature. And is pretty exciting when you think about it, that the computer is predicting as well as the clinicians who are caring for patients. That's pretty remarkable. But what's even more staggering is the model is much better than clinicians at predicting ICU transfers, not quite as good at predicting palliative care or the other just sort of deaths alone. But perhaps the most important thing is that if we combine the model and clinical predictions, you can see that everything improves. So combining human and model predictions improves our detection of outcomes by 16% compared to clinicians alone, and by 24% compared to the model alone. So it's really the combined, which is what's going to happen in the real world, right? When you deploy this, it is the combination of human and model predictions that is going to influence care. So that gave us some real confidence to share with our clinicians that, look, this seems like it's going to be useful. The model is going to provide you with new information that is going to complement the care that we are providing. I mentioned we had a weekly implementation team. I won't go into all of these examples, but what I'll say is that we adopted a PDSA approach, a sort of typical QI approach where individual issues were identified on almost a weekly basis after deploying. As an example, one of the teams received a totally erroneous alert, no idea how it happened in the middle of the night. They realized they had no one to talk to or ask. We realized we needed a plan for 24/7 tech support. We implemented that. And similarly, along many different approaches, we adopted that iterative approach, very much taking a QI mindset of improving the solution once it was deployed. And so these are the results of the formal quantitative evaluation. So what you can see here on the there are two groups. So we deployed ChartWatch only on the general internal medicine unit, and these are subspecialty units. So these are all patients who were admitted on a respirology, nephrology, or cardiology unit, the other units in our hospital that had some comparability to a general internal medicine unit. The outcome here is deaths in which the patients did not receive palliative care. So a composite of prevented deaths in general, and also improving the palliative care delivery. So it was a combination of the two, which I mentioned is really what our objective was. What you see here is, so pre-intervention was the 3 years before we launched the intervention, which was in the fall of 2020. And then this is about a year and a half after the intervention. And then this is the areas where it was not deployed the same time period. And you can see quite a large difference in non-palliative deaths on our unit in GIM, with, at the same time period, no change in our subspecialty units, telling us that we were making an impact, and happy to go into this more deeply if it's helpful. I'll just conclude by sharing a couple of stories of how we think this is actually making a difference. So this was an email I got within the week after we deployed ChartWatch from one of our staff physicians, saying that there was a lot of sort of questions about how does it know when things go wrong. And here's a specific example. The resident on call received a high-risk alert around 11 p.m. She went and reviewed the chart, saw the patient as per the recommended protocol. He was stable. Approximately 2 hours later, she received a call from the nurse that the patient was decompensating. Because she already knew the patient, she was able to quickly assess at the bedside and get the ICU team, the CCRT, critical care response team, involved. The patient went to the ICU but did not have a respiratory arrest, which was certainly a risk if the intervention had not been done as quickly. She feels that ChartWatch made a big impact. And I mentioned that's exactly what we're trying to do, is expedite care, improve coordination, try to improve the escalation of care when there's a need for it. Similar example, here was a patient at the tail end of COVID symptoms, was getting ready to go home, suddenly became a high-risk alert, so they didn't discharge the patient, and then all of a sudden started needing oxygen. Turned out she had a pulmonary embolism. Not really sure why. Still intrigued. So in general, residents felt that a ChartWatch high-risk alert was causing them to pause and think more deeply about a patient, which is exactly what we're trying to achieve, again, with the triage tool. This was a story of a patient from a shelter with a history of schizophrenia, recurrent aspiration pneumonia, had a background of lung disease, bronchiectasis, had multiple previous admissions resulting in a revolving door in and out of the ICU. In this context, palliative care was activated as part of the ChartWatch alert. We send an automated trigger to palliative teams. They don't always consult, but they check in and ask if a consult would be helpful. And they had never been involved on prior hospitalizations. The patient deteriorated, but actually this time was able to express their wishes that they preferred comfort-based care and did not go to the ICU, and he passed away peacefully on the unit. In our quantitative evaluation, this looks like a failure. This looks like a missed event by the program. But qualitatively, to me, this is an example of a person who was vulnerable, who had not received access to palliative care because for whatever reason, the teams previously had not thought about giving palliative care to this patient, or maybe were unable to engage and really elicit their preferences. And I think we could postulate why that might be. Someone with sort of coinciding conditions of social and mental illness, social vulnerability and mental illness. And here's an example of where the algorithm of ChartWatch, which cannot see that the person has schizophrenia or that they're homeless, has an automated alert that brings access to this service, right? We hear a lot about how algorithms can be biased and can amplify bias, and that is true. But I think there's also, we know that humans are very biased, and there's an opportunity for our algorithms to potentially correct some of those biases as well. So that's one example that I found very heartening. And I'll conclude with one example that reminds us that it's not all rosy and there's work to be done. So our resident went to speak to a patient after a chart watch alert, asked the patient whether they'd be interested in receiving palliative care, because that's kind of part of the algorithm. And it made the patient angry and they did not want to be cared for again. So there's an opportunity here where we really need to teach our trainees, teach ourselves as clinicians, how we talk to patients about these tools so that they don't damage the therapeutic relationship. So that's the final slide. Thank you so much for the opportunity to share our work, and happy to chat further.
Thank you, Amol Muhammad. Really amazing talk. And I have a long list of kind of questions in front of me to ask, but a lot of them, I guess, you touched upon during the talk. Maybe I can ask you a kind of a very general question, and also then ask the audience, because we're kind of about 10 minutes kind of away from the end of the meeting. So one of my former students, I guess, was kind of one of the lead authors on a paper from Google, the MedPalm 2 version that recently came out, and it was called Towards a Generalist kind of AI in Medicine, I guess. When I'm looking at your, chart watch kind of approach, it's very specialized to this specific application. Yeah. Do you anticipate that, like, approaches like ChatGPT that are becoming fairly common and become more generalist, is there an opportunity in medicine to build such approaches, or you think that actually generalist is not the right approach and specialist is the way to go?
Mohammed, do you want to take that first? Do you want me to go first?
Yeah, why don't you go ahead?
Okay, sure. Yeah, thanks, Purang. Great question. What you're referring to, this idea of a foundation model. So can we have a model that can understand context more generally, and then can accomplish a lot of different tasks, like be a generalist, as opposed to, we began this work in 2017 before the explosion of those large language models. And you're right, like all of the AI development in medicine before that was very specialized. So predict this specific thing. I don't know yet. I think that I think the idea of foundation models is really exciting, and there are people working on developing foundation models for medicine. So there are a number of scientists in the Toronto area that some have created similar chatbot style things, but there are others who are working on what they call multimodal models, so that they could take imaging and lab data and free text data, et cetera, and really essentially develop a model maybe that predicts the next patient's state. Now, you have to think it's a little less obvious in medicine. So it's, in one sense, you can understand what a foundation model for a language looks like, because you're predicting the next word in a large body of text, like all the text on the internet. But what is the next word in a patient? Right? What is that data? So you could predict the next word in a medical record, but we all know that the electronic medical record is flawed in terms of it's a very biased representation of what actually happens in real life, like filtered through the lens of the clinician who's busy, who's copy pasting, et cetera, et cetera. So I think it's not so obvious to me that if you could just train a model that can predict the next word in an electronic medical record, it can then be a multi-purpose health tool, right, in medicine. So I think we still have to figure out, what does a foundation model in medicine look like? Having said that, people have done it for example, foundation models for retinal imaging was recently published in Nature. And so I think it's kind of somewhere in between, like a specialty version of a foundation model that then allows you to train lots of different applications, but it does help with a lot of the pre-training to getting towards something that's really useful. So, but I'm excited to see. I mean, it's amazing that ChatGPT already does so well on medical knowledge. It's not really at the level that it's reliable enough to be useful for high stakes decisions, but I think foundation models are a really exciting way forward. It's not so obvious to me that we have the data in clinical medicine to know how to train one that's going to be really useful for clinical decision making yet.
Great, thank you.
Maybe I'll add too. So I apologize as soon as you asked the question. My daughter texted me and thought it was urgent, and apparently it had something to do with Starbucks. So I think what Amol said is bang on. I imagine a lot of these general models, though, in order to get to that level of performance, become specific models. So I'm not really convinced that a very general approach, at least currently, would really apply to a lot of cases in medicine.
Okay, thank you. I think Teresa has a question. Teresa?
Oh, thank you so much. First of all, on behalf of Dash, I wanted to thank Dr. Verma and Dr. Mamdani for joining us today. Really appreciate that, and your presentations were tremendously inspiring. So I have a quick question for Dr. Verma particularly. I am in awe of how you developed the 3 phases for machine learning implementation for QI. Now, first of all, it reminds me very much of the decision support tools that we already have in most hospitals. Very much sort of a similar organization. You have computer scientists, data scientists, clinical people, and developing decision support tool to alert us in some way. So I want to ask, number one question is, how is your setup different from the usual decision support tools that, as I know, are available in most hospitals? So that's number one. Number two is, from my experience, is that hospitals generally do not put a lot of financial support in terms of developing, for example, creating opportunities for data scientists right at the clinical site, and AI specialists and all of that. How do you convince your hospitals to invest in those individuals that help us to develop the best AI algorithm? Those are the 2 questions. Thank you so much, Dr. Verma.
Thanks so much for having me. Thanks for the great questions. The first one is actually my answer to the first question, which is, how is it different from a typical clinical decision support? In a lot of ways, it's not, which I think is actually the good thing. AI is a digital computer-based solution that draws on a lot of what we know already from QI, draws on what we already know from health IT. So it's an evolution, not something like totally quantum leap in that sense. And so I think that's great. Like teams, we could draw on our clinical informatics specialists. We could draw on, the teams that already exist within the hospital that are working around clinical decision support. And so I think that that's actually a good thing. There's one major thing that's different. You could parse it out a few different ways, but machine learned solutions are very complex, which means they may not work the way we think they are working, right? And so that means you just have to, there's a few things from a technical perspective that change, therefore, when you're deploying a machine learned solution. So the first is, obviously, you need the technical expertise. You need someone who can actually do build your machine learned model or deploy a machine learned model in your solution within your IT system. And that requires robust infrastructure, right? It requires the ability to actually get data out of the EMR, have a place that you can run models, and then push those models back into some kind of system of communication or whatever, back into the EMR or paging or whatever. So you need IT people that can figure that out, and you might need local compute. Like our hospital had to buy GPUs, for example. So I think that the actual infrastructure is different. The second piece of what's different is, unlike a typical clinical decision support rule, like let's say drug A interacts with drug B, so don't prescribe it, that remains true always. You don't have to worry about that's going to be untrue in a week or 2 from now. A machine learned solution could stop working so well. Maybe a lab test changed and it no longer performs the way you thought it did, or maybe your patient population evolves. And so it's something that needs careful ongoing monitoring. And so that's why we built in that like most QI implementations, they'll have maybe a team that meets weekly while you're refining your tool. But at some point, you kind of just say, okay, that's part of operations, right? But for us, actually, that implementation team still meets monthly. And we have a lot of the data pipeline set up to make sure it's monitoring for, this input into the model is still running as we expect, et cetera, et cetera. So I think the careful monitoring and attention is critically important. And that's different. And so that actually brings me nicely to your second part of the question, which is how do you convince, it takes resources. How do you convince the hospital to, invest? I would say from our end, I didn't have to do any convincing. That's actually Mohammed's job. And so we were really fortunate, and I'll leave it to him to respond. But for me, I got to train. So this was the work of my post-residency research fellowship. And the hospital said, like Mohammed said to me, what should we do with AI? The hospital made this an area of priority and interest. So for me, it didn't take a lot of convincing, but I think how we as a community are going to convince our organizations to invest in these areas will be by demonstrating improvement, right? Demonstrating impact, just like anything else. But Mohammed, did you want to respond to the idea about investment?
Yeah, sure. I mean, I think practically speaking, we've got to tackle problems at the C-suite, problems that resonate with the C-suite because they have the resources, right? And one of the first projects we took on was around right staffing nurse resource teams because we're spending a lot on agency and overtime, and it boiled down to dollars. So we had optimization algorithms that we deployed fairly quickly, and we didn't do the cost calculations. The nurses did. The estimated annual cost reduction for our deployment at 2 hospitals was $1 million a year. And so when you start saving money, that resonates quite a bit. And then you have an environment with brilliant clinicians and scientists like Amol, who can really take ownership on the clinical end, and you start seeing clinical benefits. It becomes really easy to justify.
That's great. Thanks so much.
Thank you.
Thank you so much. Nicholas, please.
Oh, hi, thank you. That was a great talk. It's really interesting. I come from a totally different world, not knowing much about AI, but it was really interesting to hear the comments that your end users had about how it seemed like it was a black box and how did it know. And I think coming from the pathology lab medicine world, I've heard that as well, where you feed all these data points into an algorithm, goes into the black box, gives you a prediction, and you don't know how it came up with it. Do you think in the future we'll get to a point where it will be able to tell us how it reached that decision so that we can learn from it as well and improve our practices?
Yeah, thanks. It's a great question. So there's the field of interpretability, like understanding how AI models make their predictions is a very rich area of research. There's basically 2 approaches to interpretability. You can have inherent interpretability, so you can train some models that are inherently explainable. So like a logistic regression model can spit out the coefficients for each model, right? But the more complex models are very difficult to understand. And so there's what they call post hoc explainability. So you basically build a separate model that then predicts how the first model is working. And it gets complicated. And I think many people, I would put myself in this category, are a little bit skeptical that those post hoc efforts at explaining how models work really tell us how a model is working. They give us some intuition about how models, what factors a model is taking into consideration. But I don't think that especially as the models become like so complex with billions of parameters, it's really hard to understand. So, but the analogy I use and is that we also don't know how a lot of medications work in the body, but we're willing to use it as long as it meets the threshold of being safe and effective, right? And so I think we have to think about how does the black box nature frustrate, like does it frustrate clinicians? How do we get them to anticipate that and include it in their workflow and get over it? And that's kind of comes back to that care pathway. We gave people clear instructions about what to do for high-risk patients. So I think it helps mitigate some of that frustration from the black box problem. But you're right. I'm optimistic that we will have some techniques to understand how models are working, but I think at best they will be guesses.
Any other questions? Actually, we are at 1 o'clock. I have a ton of questions, but I guess we have to close this meeting. David, any comments? Teresa?
No, I think it's just outstanding. And thank you so much for our guests. And thank you so much for pathology allowing us to have this set of rounds, analytic rounds that really help us to set up a nice stage for collaboration between pathology and medicine as well. And thank you so much. And thanks, Purang, for standing in for me as well, because I'm just practically losing my voice and coughing all the time. So I didn't want to take the risk
No worries.
of doing it today.
No
Thank you
worries,
so
my
much.
pleasure. Great to see everybody. David?
Yeah, well, thank you for giving us, a glimpse of the future of clinical medicine. And I know there are a lot of opportunities in our domain to work on similar projects, and I hope collaborating with your institute and your team. So thank you.
Thank you so much, Mamdani and Amol. Really appreciate it.
Pleasure. Thank you.
Thank you. Have a
Thanks for
great
having us.
Bye, everyone.
Thank you. Bye.